that I'm, having the opportunity to give you this lecture. As you know, I know a lot, and I'm not really sure if sometimes I'm too short on the slides or, but I really want to do it as a little bit of the interaction with you guys, and you can stop me anytime and ask those questions. I don't consider to be rude. Then it's really difficult. I do remember listening to some of those lectures when I was in your shoes. Back in downstate. I cannot start giving you this lecture without reminding what a big loss we had this year, losing Professor Maccabi. I cannot keep my emotions apart. I hope I can. He was an amazing electrophysiologist. Neither one of us can do that. It's above and beyond what he did for all of us, the fellows in neuromuscular, for some of your attendings that you have there for me personally, and I hope you guys are going to learn from me a little bit. Not the same as you could have learned from him, pretty sure, but I'm here to help you. And then if you want to go in this direction, let me know. You have Dr. Anziska and Dr. Quirk and Nuri Jacobi on the other side, but you always have me here. Then if you want to ask any questions and have any difficult cases, let me know. Then let's start with some questions. Then let's say we have a decremental response on slow repetitive stimulation. Then we're going to talk today about repetitive nerve stimulation. Then decremental response on slow repetitive stimulation is commonly seen in all of the following, with the exception. Now let's see. Botulism, amyotrophic lateral sclerosis, myasthenia gravis, corticosteroid myopathy, or LEMS. What do you guys think? What should be the exception?
So obviously myasthenia is not the correct answer.
No.
Botulism and
Ahmed, you have to find the exception. Yeah, okay. Myasthenia is not the correct.
The obvious ones, because it's between Lambert-Eaton, when it's slow, it decrements. So it's between amyotrophic lateral sclerosis and corticosteroid myopathy.
Very good.
Myopathy.
Very good. But we need only one answer. What do you think would be the best answer?
Myopathy.
The corticosteroid myopathy. Yes. Then every other possible answer that we have here, exactly like Ahmed mentioned, are having decrement. Now, botulism on slow repetitive nerve stimulation will show a decremental response. Amyotrophic lateral sclerosis, despite the fact that it's a motor neuron disease, has pathology that involves neuromuscular junction. Then it's not a neuromuscular junction disorder, it's a motor neuron disease, but does have neuromuscular junction pathology. And then we can talk more about that if you are curious about myasthenia, you guys know. LEMS, the same like he said, a slow repetitive nerve stimulation, which is between 2 and 3 hertz, will show a decremental response. Myopathies can do that too. Corticosteroid myopathy is not very typical of doing it, but you can see some decremental response on patients with chronic myopathy, especially the ones who have muscular dystrophies, for example. No, that's a very good answer. Let's do another one. Now, in patients with suspected ocular myasthenia gravis, which test is most sensitive in establishing the diagnosis? Checking the antibodies for acetylcholine receptor, single fiber jitter study of frontalis muscle, slow repetitive stimulation of the facial nerve, slow repetitive nerve stimulation of the spinal accessory nerve, or single fiber jitter study of the extensor digitorum communis.
Hi, Dr. Treidle. I'm not sure if it's the most sensitive, but I think single fiber jitter for the frontalis muscle should be for ocular myasthenia.
Yes, then it is the most sensitive test. Then single fiber EMG is the most sensitive test that we have for myasthenia gravis. That's the reason I'm giving you the lecture today. I know that my colleagues do not do single fiber, but if you have a case that has negative antibodies, your repetitive nerve stimulation won't help you too much. We're going to talk later why. Then the most sensitive should be single fiber EMG and single fiber jitter study, as mentioned in this question. Now, the problem was which one you pick up as a muscle to study. Would you pick up the frontalis muscle, which is answer B, and your colleague was correct, no? Or would you pick up the extensor digitorum communis, no? Which is the most common single fiber muscle used. Professor Maccabi was using extensor digitorum communis. Then the correct answer would be frontalis muscles. And is somebody that can tell me why? James? Because you answer.
I'm not sure why. Maybe because it's close to the eye.
No, but then look what I said in the first part of the question. I said suspected ocular myasthenia gravis, no? Then you go to the muscle that's weaker. Frontalis muscles is helping the elevation of the eyelids, no? That's the reason you are going for that muscle specifically. You can test extensor digitorum communis if you have more a generalized clinical presentation, no? And for you to know, it's a very interesting clinical presentation. If you remember, myasthenia gravis affects which muscles most common? The proximal muscles of the body, of the limbs, or the distal ones?
Proximal.
The proximal, no? And why is that, Dima? Do you remember?
The temperature. It's
Yes.
higher temperature to next to the core of the body.
Correct. No, then the proximal muscles are going to be closer to the body, which has the heart very close, receive more blood. It's the temperature is higher, no, it's warmer than proximal muscles are the one that you study. Then see, many physicians prior were using extensor digitorum communis because you're going to see later on during my lecture, it's a very difficult study to do. And it's difficult because the hand of the physician has to be steady. You don't have to have any shakiness, no essential tremor, no. But also the patient has to be steady, no. Then imagine how difficult it will be for the patient to do abduction, no. And you put the needle in the deltoid muscles to do this prolonged testing, which takes maybe 1 hour and more than 1 hour, comparative to doing an extension of the fingers. In general, we select the middle finger and you extend it. It's part of extensor digitorum communis. You can keep the arm and the hand on the table, examination table, and you can put a little bit of a towel underneath, and then the finger can stay up a little bit better for the patient to do that voluntary study, no? That's the reason extensor digitorum communis was used most common. But you have to know that most of the time, the proximal muscles are affected more than the distal. And you might have a surprise to have a negative study here too. Then nothing is 100%. No, the sensitivity goes up to 99%, but sometimes you have to be careful on selecting the muscle. If the patient has extension of the elbow weakness, which was described to be particularly affected in patients with myasthenia gravis, you will see changes on this muscle on single fiber EMG. And only for you to know, then most of you are going to do critical care or stroke or other type of neurology, no? But you will get a case that comes with some papers to you, and you're going to look at those papers and you remind my lecture about what muscle the electrophysiologist has chosen to study for you. Okay? Good. Now another question. In patients with suspected ocular myasthenia, which test is most specific in establishing the diagnosis? Let's see. Acetylcholine receptor antibody testing, the single fiber jitter of frontalis, the slow repetitive stimulation of the facial nerve, the slow repetitive for spinal accessory, or single fiber jitter of the extensor digitorum communis.
I think it's the antibody, right?
Yes, perfect, Ahmed. And Ahmed knows everything. You should do neuromuscular then.
Well, thank you.
It is a difficult question, but why I wanted you to have those two questions about the most sensitive and the most specific is because you're going to find them on your exams. It's going to come on your right exam. It's going to come on your boards. There are doctors like I am, and I usually like to puzzle my residents here at Stony Brook and ask them those questions. And most of the time I trick them. They don't know it, no? Then now you should know those questions. They're very useful, sensitive versus specific. Okay. Factors that increase the utility of a slow repetitive stimulation in myasthenia gravis include all of the following with the exception. Let's see if you know this question, and I promise that's my last question here. Should be slow repetitive stimulation recording a weakened muscle, should be slow repetitive stimulation before and after exercise, a slow repetitive stimulation recording a proximal muscle, a slow repetitive stimulation soon after taking the pyridostigmine, or slow repetitive stimulation on warm limbs. You have to find the exception.
I think it's D because the pre-segment should help the muscles. So it's the only
Yeah.
thing that's going to make it more strong.
Yeah, perfect. That's correct, Ahmed. It's correct again. Then what's happening? You do slow repetitive nerve stimulation in the weakest muscle possible, no? Then there's a reason this test is not going to help you all the time because it's done in ulnar nerve, no? Repetitive nerve stimulation of ulnar nerve, of abductor digitivinini. And this one may be strong in myasthenia. We spoke about proximal being weaker. Before and after exercise, no? Because if you do it before, you're going to see what's happening when you stimulate repetitively the nerve and the muscle activates, and what happens after exercise when you fatigue that muscle, no? Then the nerve and the muscle. Recording a proximal muscle is the most important part of the repetitive nerve stimulation, and warming the limbs, like Dima said, no? Having a warm temperature comparative of a cold temperature. If you do it on hands, my hands are cold right now because I'm afraid that you guys are not going to like my lecture. Then if you do my repetitive nerve stimulation on my hands, that's going to be a negative study. I'm not going to have myasthenia, no? But if you do it on a proximal muscle, which is warmer, you can get a positive repetitive nerve stimulation. Then for you to understand that all those limitations are present in day-by-day EMG lab, then it's very common for us to have patients which are cold, they are anxious, no? And you do a repetitive nerve stimulation on the ulnar nerve and distal, and then you get absolutely nothing, and you send a message back to the physician that the test is negative, and in fact, the patient can have myasthenia, no? Then what we in general do, we go for the facial nerve and we stimulate repetitively a facial nerve, could be called too. And then we also use the accessory nerve from time to time to do it. But the problem with the facial nerves and the accessory nerve that is recording on the trapezius muscles, the patient is going to move when you stimulate them. It's a painful test, no? And then you have to find a way to calm them down, relax them, but it's difficult. It's really painful. It's not an easy test to tolerate. That's the reason repetitive nerve stimulation most of the time could be read by the electrophysiologist as being normal or abnormal due to the artifact, no? Now let's do a case, and after this case, we can go a little bit in the deep of the electrophysiology of the neuromuscular junction. Then we have a 62-year-old man who presents with asymmetric right eyelid ptosis for 5 years, and he underwent corrective cosmetic ptosis surgery 5 months before. After a few weeks, he noticed that the ptosis had reoccurred. He reported occasional diplopia that seemed skewed, fluctuating, and improved with closing either of the eyes. He denied dysarthria, dysphagia, dyspnea, or limb weakness. And on examination, he does have right eye ptosis that worsens when you keep a sustained up gaze for 1 minute. And after 5 minutes of eye spark test, ptosis improved significantly. There is diplopia on sustained up gaze that seems skewed after 15 seconds. And otherwise, he has full strength in his facial and limb muscles without fatigability. Laboratory studies were negative for acetylcholine receptor antibodies. And now the question is what we should do to diagnose this patient. Then as you can see, it's a very clear case. Now, if you read a case presentation on internet, on one of the good papers, you're gonna immediately say, oh God, sounds like myasthenia, no? Then the ISPAC test will help you in emergency room to pick up a ptosis that comes from the neuromuscular junction comparative with the cranial nerve third or no? Then it's really helpful. But most of the time, those patients are a little bit picky, and I will tell you why. Then this is his picture, and then he came to us and he was very concerned. He said, I went to so many doctors and they are telling me I have nothing because all the testing is negative right now. And they, give me all those shocking tests, and all those shocking tests are negative. And what do? Then at the end of the day, my eye droops like that, and I drive the car and I start seeing double, and I cannot help my wife with things that can be done nighttime. Then what do I do? Then what do you guys are gonna tell him?
So should we also check anti-mask antibodies? And this is something, and we can send him for EMG and check for single fiber as the most sensitive.
Yeah, then I would say that's a good question saying about anti-mask antibodies, but anti-mask antibodies will not present with pure ocular symptoms. If you recall my vignette, now on presentation, I said very clear, denied dysarthria dysphagia. No, then very common anti-mask myasthenia will come up with dysarthria and dysphagia. They have bulbar symptoms. All patients with myasthenia have ocular symptoms, then you can call them ocular bulbar, but mask antibodies will have more bulbar symptoms. There is another antibody that you need to ask for it along with anti-mask.
LRP4, we can check and send them for a CT chest for a possible time on this.
That's correct. Johannes is correct, and he's correct in regards to LRP4 because LRP4 antibodies myasthenia does present with ocular symptoms. It's really the one that we didn't know about before those antibodies were discovered and reported. And most of those 50% of ocular myasthenia gravis, which are negative, might have had something over there that was LRP4. In general, it's a very slow percentage, 1 to 2% of patients, but you have to know about LRP4 more commonly with ocular MG than anti-mask. Yes, you're gonna do a CT chest because you want to be sure that the patient doesn't have a thymoma. Do it. From my experience, I will tell you that the moment they have negative antibodies, if those antibodies were repeatedly done in different laboratories, because you can have a negative test because of the laboratory testing. You have to do cell-based assay testing. And if they go to Mayo Clinic, you're sure that they are negative. But other laboratories can make mistakes because of the technology. But then do a CT chest to be sure that you don't have thymoma. In general, the ones who have negative antibodies and no acetylcholine receptors do not have thymoma. Do they have a rest of the thymus that you want to take out later? Yes, they can. Then I think having a CT chest is a good idea. Okay, then like your colleague said, we should do a single fiber EMG. Then in the end, that patient had a single fiber EMG. We talk a little bit later, but the single fiber EMG done recorded around 27 pairs. Here you can see the numbers. And that's a typical jitter of the second motor unit potential recorded by this physician. And he calculated here, he's lucky he has an electronic machine like I do that calculates everything for you. and the mean that he recorded 35, if this muscles was like he said here, frontalis, it's above the norms of a normal patient. And in frontalis, with the new machines and the new needles that we use, concentric needle EMGs, those numbers are above, they should be less than 25 microseconds. I'm talking about the jitter. Then this is how you solve a case, no? And in the end, this patient was had sent out LRP4 antibodies. And he is one of the rare cases I have with LRP4 antibodies positive. Do you have any questions about the questions I asked you and about the case? No? Then when you have a seronegative myasthenia gravis, your clinical presentation is very suggestive of it. The patient is asking you lots of questions, send them for single fiber. It's the most sensitive test. You can always look for those antibodies, as we mentioned, especially if you have more ocular symptoms. You can ask for anti-mask if they have more bulbar symptoms. Now, neuromuscular junctions are among the most interesting and rewarding disorders in the EMG lab. And why is that? Is because you really can diagnose them if you know what to do, and you treat them. And then, as I mentioned earlier, you're only making a joke with your teacher, Dr. Lowe, you treat those people. They usually don't die, no? It's a very rewarding subspecialty neuromuscular. Most of our patients, with the exception of ALS cases, are treated, no? There are case by case and situations, but I will say it's a very rewarding subspecialty. Neuromuscular junction disorders are immune mediated, and you know some of them, no? Myasthenias and LEMS are toxic, no? And that's one of very classical one, botulism, or there are some snakes that can do that too. Metabolic, do you guys know metabolic abnormality that can look like neuromuscular junction disorder, like myasthenia? Is in general, yeah. Go ahead.
Hypocalcemia or hypercalcemia mimic.
Yeah, what about if you are on an OBGYN ward and you are consulted by the OBGYN doctors for a preeclampsia case? No? Then hypermagnesemia is hypermagnesemia is the classical one that you can see as a metabolic neuromuscular junction disorder. Then if you give them too much magnesium, they will behave like a myasthenia case, okay? Good, and congenital syndromes, there are congenital myasthenic syndromes. The electrodiagnostic studies in evaluation of those patients should not be limited to repetitive nerve stimulation and single fibers. You always start with nerve conduction studies and then you add the needle EMG. And why you do nerve conduction studies? Because you want to be sure that you are not dealing with a neuropathy or a motor neuron disease. Now, and why you do the needle muscle is the same. You want to be sure that you are not dealing with a myopathy, a neuropathy, or a motor neuron disease. The role of neuromuscular junction is to transmit the action potential from the motor neuron to the skeletal muscle fiber for a sustained muscle contraction. Neuromuscular junction, or the end plate, is a very tiny structure on skeletal muscle fibers. And depending on the muscle fiber type, its length ranges from tens to a few hundreds of microns. Within the muscle, a motor axon forms multiple branches, each of which connects to a single skeletal muscle fiber, typically in the center region. This is a very nice paper that shows you the branches of the motor axon at the neuromuscular junction, the end plate. This is an electronical view of the neuromuscular junction in a mouse. It looks like a pretzel. It's not the same in humans, but it's very nice picture. And then that's a nice picture showing to you what's happening. Now you're gonna have the distal motor axon. The impulse goes to the presynaptic area now where you have these vesicles with acetylcholine, and then you have lots of proteins that will help, and gated channels for sodium, for potassium. Then you got your synaptic cleft here, and then you have the postsynaptic area with sodium and also with the calcium gated channels and the acetylcholinesterase. Now that's very helpful. And lots of other proteins, the MASC, the LRP4 that we already mentioned, rhabsine also. Now all those proteins are very important in different type of neuromuscular junction disorders. It's important to know. Then the most distal branches becomes devoid of myelin and form the presynaptic nerve terminal, then opposes the specialized postsynaptic area. The small distance in between them is called the synaptic cleft that I showed to you. The nerve terminals contain the key elements which are responsible for the controlled release of neurotransmitter, the acetylcholine. And acetylcholine is present in what we call them quanta, more or less fixed as an amount, close to 10,000 molecules, and contained in these synaptic vesicles. This is a very nice electronical microscope electron picture, which shows you the synaptic cleft, the synaptic vesicles. This is called the active zone, where everything is happening, where the acetylcholine is liberated from the vesicles, and these are the postsynaptic folds. A very interesting picture from mouse muscle. This is another nice schematic presentation when you have your distal axon. These are the voltage-gated calcium channel in the presynaptic area, the mitochondria, which are also helping, the vesicles full of acetylcholine quanta, the receptors, which are in the folds of the postsynaptic part of the neuromuscular junction. Then these are the numbers of the vesicles, plenty of them to have a backup when you need them. No, the membrane has a phospholipid bilayer that contains several of those membrane proteins. Some of them I mentioned already, showed to you, some of them I haven't. The SNAR proteins, which you need to know because they are helpful in diagnosing some of the congenital myasthenic syndromes and are the ones which are attacked by toxins now, it's a snake or botulism now. And they are also helping to connect to the calcium voltage channels and really are part of the presynaptic transmission of the information. No? Then in the central functional, the central functional protein, which is this in active zone I showed to you, it's the voltage calcium channel, which is very, very important, especially the PQ type ones, which are attacked by immune pathology in Lambert-Eaton myasthenic syndrome. And another key molecule in that synaptic cleft should be the acetylcholinesterase, responsible for degradation of our neurotransmitter. Laminin B2, it's very important too. There are some congenital myasthenic syndrome which are missing this type of protein. And the postsynaptic will have these wide folds, which are the healthy part. If you get myasthenia, the folds are going to be flat. And as long as you get into many, many years of going around doctors and not being diagnosed, that folds are going to be really, really flat and you cannot help them too much. Don't forget the acetylcholine receptors are nicotinic type here, no? The duty of the neuromuscular junction is to transmit each motor neural action potential into the innervated skeletal muscle fiber. A malfunction of any key factors that we mentioned will affect the transmission. Despite of having a large safety margin, which we're going to talk about, it will block the transmission in the end, no, because that margin is going to be overcome by the continuous stimulation of the muscles. This will cause muscle weakness after sustained contraction, then requires a certain duration for repetitive muscle action potentials, and the defects caused by genetic mutations, autoimmunity, or intoxications will be seen similar. Now you have only to know the history and pick up what could be the cause of those defects. The inside of motor neurons and the skeletal muscle fibers are negatively charged comparative with the extracellular space. If you remember the resting membrane, it's around minus 80 millivolts, and the presence of ion channels enable them to generate and transport the signals in form of depolarization along the membrane. Sodium channels and potassium channels will have the depolarization and repolarization. And the presynaptic voltage rectifying potassium channel are the target for the antibodies in autoimmune neuromyotonia, if you remember, and for the snake venoms, which behave like myasthenia gravis. Once a motor axon action potential reaches the nerve terminal, it causes opening of the calcium channels at the active zones, which I showed to you. Increasing calcium concentration will activate the exocytosis of the several acetylcholine quanta. The chance of releasing the acetylcholine quanta from a single active zone in the response to an action potential is only 10%. Several rare disorders are associated with this transmission in the presynaptic, and you know about them. Then if you diminish the transmission, the postsynaptic end plate potential is not going to be large enough to trigger the muscle action potential. And the prolonged synaptic activity will cause some degrees of quantal content increase due to accumulation of presynaptic calcium, but not enough to make that muscle contract. Now, in LEMS, what is happening is that if you activate those patients and you ask them to do some exercises, you will help the calcium to go into the muscle fibers in the presynaptic area, and then the patients are going to get a little bit stronger, no? And a medication that you know is used and approved in LEMS is this 3,4-diaminopyridine, which will go and block the delayed rectifier voltage-gated potassium channel, which I mentioned to you. In the postsynaptic area, you have that acetylcholine, which is diffusing into the synaptic cleft. A large part is degraded, but the rest of them is gonna work on these receptors, which are pentameric ligand-gated ion channels. You're gonna see the picture. I'm gonna show to them what I mean by the pentameric ligand-gated. To induce this opening of the pore, an acetylcholine molecule must occupy each of the two binding sites of acetylcholine receptor. I will show to you. And those channels under physiological condition will allow the influx of sodium and the efflux of potassium and influx of calcium. Now, the multiple quanta released simultaneously in a response to a presynaptic nerve impulse will give rise to the end plate potential that stimulates the opening of sodium channels and forms the muscle fiber potential. This is the pentameric picture, then 1, 2, 3, 4, 5, 2 of them of alpha. These are the pores where the acetylcholine it's gonna bind on the receptor, only those two ones, no? Then a safety factor of the neuromuscular transmission exists in the neuromuscular junction. It means that the actual end plate potential amplitude is much larger than the minimal needed to reach the firing threshold. Then this safety factor in neuromuscular transmission is necessary to assure that the transmission, even when upon intense use of neuromuscular junction, the acetylcholine is going to be released and shows a rundown. Now, then you run down an acetylcholine because of the continuous activation, and because of the safety factor, you're going to be able in the end to produce an end plate potential and activate the muscle. The hallmark of myasthenia is fatigability. Now it's due to the progressive transmission failure. Most of myasthenia patients will have these Ig1 and Ig3 antibodies against postsynaptic acetylcholine receptors, 80% of them in generalized type of presentation and 50% in ocular ones. Their antigenic binding has multiple effects, cross-linking the acetylcholine receptor and causing their internalization. A direct functional block on the acetylcholine receptors for the blocking ones, or complement activation with the focal postsynaptic lysis due to the membrane attack formation. The end plate potential caused by multi-quantal acetylcholine release evoked by a nerve action potential becomes reduced in amplitude by reduced acetylcholine receptor density. Then if you reduce the density, you're going to have less places to action, and then because of that the muscle will get weaker, no? And the safety factor becomes reduced. Despite the fact that you have enough safety factor, you don't have those receptors to act on, and that's how myasthenia gravis comes up with muscle weakness, no? End plate potential may be too small to cross the firing threshold, especially when you activate intense that muscles, and in severely affected MG patients, and potential may be so reduced that the first end plate potential of high frequency is subthreshold, then you're not going to get any activation. Muscle fiber will not contract. And another important part is the concomitant removal of proportion of the postsynaptic sodium 1.4 channels, which are on the folds. Now, if you remember, and those folds are all flat and you lost those sodium channel and you don't have any possibility to do the depolarization, no? The complement attack disturbs the geometry of these postsynaptic folds and then make those channels to be less efficient. The anti-mask has a secondary effect also on those antibodies, and it is dispersal and removal of the receptors on a smaller safety factor. It has two distinctly different features. First of all, it's an IgG4 disease comparative with the other two, which are Ig1 and 3. I'm talking about acetylcholine receptor binding myasthenia and NLRP4, and then seem to lack the compensatory upregulation of the acetylcholine release in response to reduction of the postsynaptic density. Then what's happening in the binding antibodies myasthenia, those receptors will be internalized, but there is an upregulation that makes new receptors. In anti-mask, what was noticed that those internalization will not be replaced by upregulation. That's the reason the anti-mask does not respond similar with the other myasthenia gravis, cases to pyridostigmine, for example, or IVIGs, no? The use of repetitive nerve stimulation dates to late 1800s when Joly noted muscle movements that occurred after a nerve stimulation. Joly noted a decremental response following repetitive nerve stimulation in patients with myasthenia. It should be performed if there is a suspicion of myasthenia, Lambert-Eaton, and botulism. Botulism is the most important one. It's the only emergency that you have, and you should do repetitive nerve stimulation, and should be considered in any patients presenting with fatigability, proximal muscle weakness, dysphagia, dysarthria, or ocular abnormalities. During the 2 to 3 hertz repetitive nerve stimulation in normal subjects, the acetylcholine quanta are progressively depleted from the primary store, and fewer quanta are released from with each stimulation. Now, then that's the reason you get tired and you don't see the end plate potential, and the patient get weak now, and you see the decremental response. The end plate potential falls in amplitude, but due to the normal safety factor, it remains above the threshold to ensure the generation of muscle fiber action potential. When you do the rapid and repetitive nerve stimulation, it comes from 10 to 50 hertz, you deplete the quanta from the presynaptic terminal, which is counterbalanced by the mobilization of the quanta from the secondary store and by the accumulation of the calcium. It takes 100 milliseconds for calcium to be activated and pump out, no? Then the accumulation of calcium, that's the reason when you have a presynaptic disease at a slow rate, you're gonna see the decremental response. And then when you activate the patient because of the rapid repetitive stimulation and the activation of the calcium to go into the cell, then you're gonna get a incremental response. Now, the accumulation of the calcium causes the increase in quanta release, and in presynaptic, only 10 seconds of exercise will help you to see the incremental response. This is the typical normal patient when you stimulate. That's how the end plate potentials looks like. The line, the dotted line, is the threshold. This is a patient with myasthenia. You see the first stimulation reached the threshold and the second one did it, but then they went down under the threshold. Now, that's how you calculate the decremental response between the first amplitude and area underneath and the fourth one. Now, then the third one should be a patient with LEMS, no, which doesn't reach the end stage, threshold. And this is after the exercise 10 seconds or high frequency repetitive nerve stimulation, when you see how it does an incremental response, no? This is how the incremental response looks like, and you're gonna see more than 100%. If you have an 100% incremental response, It doesn't mean that you diagnose a presynaptic disorder. You can be normal and have it at 100. But what's important, if you have it more than 200, 300 as an increment, that means it's a presynaptic disease. Now then, when you have a botulinum's case in a neurocritical ICU or a LAMS patient, that you should look for this 200, 300% incremental response. Then brief maximal voluntary contraction exercise can be used instead of high repetitive nerve stimulation. Then we don't use high repetitive, I don't do it. I activate the abductor pollicis brevis for 10 seconds, and then I stimulate again. And in this way, I do a repetitive nerve stimulation at a high frequency and diagnose LEMS patients. Now, it's enough. You don't need to do anything. You do at rest, 2 to 3 hertz, you activate for 10 seconds, and then you repeat the testing, and you should see that incremental response. There is a such thing that you can get in your exams, especially write exams, not in the exams for boards. They usually don't ask so difficult questions. There is something called post-exertion facilitation, exactly like I said. Then you activate my muscles. I don't have myasthenia. You activate 10 seconds, and after that you stimulate again. You can see an increase in amplitude of the response with 100%. It's normal. Now, that's post-exercise facilitation. If you see it 200 and 300, that's LEMS. Now that's a presynaptic disease. That's another one, which is called post-exercise exhaustion. You activate now, and you stimulate the nerve repetitively, and you see how the compound muscle potential from the initial activation is going to go down. Now, that's very common could be common in us, normal patients, and very common in patients with myasthenia. No, the decremental response is going to be significantly noticed. Then what are the technical factors? Failure to immobilize the recording electrodes. I'm going to show you a picture. Now, stimuli should be supramaximal. My technician always rushes. She doesn't do a supramaximal at rest, and then when she does the repetitive nerve stimulation, she can see an incremental response. Then be sure you stimulate once, you stimulate twice, you increase the intensity till you reach a maximal response from the muscles, and then you do repetitive nerve stimulation. Temperature, as we talk about, keep the hands around 32, 33 degrees Celsius, and then stop the period of stigmine. No, then I usually ask them to stop 12 hours before the repetitive nerve stimulation, and selection of the nerve that we talked prior, which nerve you should select. This is a picture of repetitive nerve stimulation, and then you see the decremental response. That's a normal one and the decremental response. That's how you arrange the, for example, for the accessory nerve, then you put your ground here, that's on the shoulder, and this is on the trapezius. The G1 is the recording, the G2 is the neutral electrode, and this is your stimulation for the repetitive nerve stimulation. You can see you cannot secure very nicely the patient, then it can move. That is the reason it's a good muscles to evaluate, but difficult. And that's you get your decrement, which has to have a U-shaped. When you do this decremental response and you see the U-shaped, you're sure that everything was correct done. Patient didn't move, you didn't move, and everything looked like a myasthenia case. That's another recording. This time it's abductor digiti minimi. Now that's the muscle here, G1, G2 is the neutral electrode, the ground in between, and then the technician fixed the stimulator here, and then she's using the console of the machine stimulating. That's how a very nice decrement will show when you have 36-degree comparative with a lower temperature. Then you see the decremental on the muscles, and then here you see a normal response. Then the temperature is very important. Then, as I mentioned, do the 5 to 10 stimulation, get the U-shaped decrement, pay attention to the artifacts that we talk about, and the calculation is going to be a percentage, and it calculates between the amplitude and also the area under the curves between the first compound muscle action potential, and the fourth one. The machine calculates for you. You only have to pay attention. What are you getting on the screen? The increments up to 40% could be seen in normal patients. I said more than 100, close to 200 and 300 is going to be your presynaptic disease. And you can see decremental, as we mentioned, in motor neuron disease, in myotonic disorders, myopathy, and metabolic disorders. Repetitive should not be done in isolation, no? And a decrement in the ulnar nerve could be also seen in an ulnar neuropathy. Then if you have an ulnar neuropathy, don't select that nerve for repetitive nerve stimulation. Could be abnormal in 50 to 70% of patients with generalized myasthenia, especially if you know when to do it and how to select the nerve to stimulate. And it's done, the electromyography is done to rule the other two disorders we already spoke about, now in general, the motor neuron disease or a myopathy. When you do single fiber, you do single fiber when the other testing are not helping, and then when a motor axon is depolarized, the action potential normally travels distally and excites all the muscle fiber within that motor unit. The variation in time, in interval between the firing of the adjacent single muscle fibers from the same motor unit is called jitter. We all have a normal jitter. I have a normal jitter. You guys don't have myasthenia, you have a normal jitter. The most important is not to have an increased interval. When this increased interval is above the norms of normal, we call it pathological. Now, the neuromuscular junction is affected. The time it takes for end plate potential to reach the threshold is prolonged, which results in greater than normal variation between the adjacent fibers. That's your axon, the motor unit, and these are the muscle fibers. And what you want to do, you want to catch only two of them, fiber 1 and fiber 2. Then your EMG screen should show only these two fibers beating together. And you let them beat together for 100 times. And you keep the needle steady in that muscle, and you watch the screen, you catch those two fibers, and you watch for them to beat together 100 times. If the prolongation is severe enough, the muscle fibers may never reach the action potential, resulting in a blocking. I'm going to show to you a screen. That means the first one is coming, but the second one is not going to come. Okay? Then if they beat together for 25 times, but all of a sudden the second time, the second fiber decided not to come to the screen anymore. No? Is used to measure the relative firing of the adjacent single muscle fibers from the same motor unit. It can detect jitter as well as blocking. The clinical correlate of blocking is muscle weakness. Then a muscle is weak, chances to get blocking are higher. There is no clinical correlation for jitter. The advantage of single fiber is that it could show the abnormal jitter even in patients without overt clinical weakness, which repetitive nerve stimulation cannot do it. No, you have to have a weak muscle when you do repetitive nerve stimulation. Otherwise, the result is going to be negative. No? Then single fiber is reserved to electromyographers, which are well trained to do it. There's a reason very few of us, because it takes very much of your time. You spend 2 hours with a study like that. And in today's medicine, you have to see more patients to get money. Not every place allows you to do that. And on top of that, you need to know what to do. I cannot tell, as I start telling you, that Professor Maccabi was one of the best electromyographers that we had, not only here in downstate and in New York, but in the world, you know, not only for papers that he published, but his skills of having a steady hand on the muscle of the patients were above and beyond. Because if you move a little bit, you're gonna lose those two fibers. Now, if the patient moves a little bit, you lose them. Then it's very technically demanding for the patient and for the physician. There's the reason very few of us are trained to do it. You use the extensor digitorum communis. I like the frontalis muscles because most of the patients which I do are the ocular MG, non-diagnosed, having negative antibodies. And yes, it's very easy. You have a typical needle. Professor Maccabi was using a gold needle, and he was sterilizing that needle every time. It was a very good needle for single fiber. Now today, with all those infections around, we are not allowed. It's one-time needle, concentric needle, which is a little bit more difficult and has different norms to follow. The potentials have to have a shape, an amplitude of 200 microvolts, and the rising time And if you don't get what I'm going to show to you, that's not a good study, you have to repeat it. And then if a time-locked second potential is located, you can calculate this interval. If you don't have a second one, of course, and then there are other muscle motor units coming up, that's not only one motor unit, you have an artifacted study, no? And by recording these multiple consecutive firings, the machine can calculate for you what's called mean consecutive difference, is the one that I show you on my patient being 35 and above the ranges. And you have to have at least two separate single fiber pairs that you analyze to calculate a mean consecutive difference. It's gonna give you an upper limit of a jitter for each individual pair based on muscle evaluating and muscle and patient age. And then you look at those normal jitters and you compare with what you got. And that's how when you're gonna say that the patient has a neuromuscular junction or not, no? And then another thing that's very important is that you should look at the upper limit of the jitter, that we call them outliers, that what's outlying, and those ones should be more than 10% of the pairs. For example, if I calculate and I record 20 separate pairs, if I have two pairs which are having an outliers, I can call that case a positive study. No, I don't really need anything else done. Then mean consecutive difference or the upper limit of a normal jitter must be abnormal. And in general, in a neuromuscular disorder, both are abnormal. Blocking may be seen in single fiber, but doesn't really have to be present all the time to call it. In general, it's present if the muscle is very weak. You have to look for 2 times locked single fiber muscle potential from the same motor unit, normally firing together, then exclude the other motor units participating. And if the trigger potential fire is steadily while the second only intermittent, you're going to see the blocking. Now, these are the pictures. Now, that's my first fiber, muscle fiber. That's the second one. You see how they beat together. And now if you look at the second picture, you see a delay. This one is delayed, then comes back to the normal. That's the jitter, the delay, the interval in the between the potentials. And on the third pictures, you see how this one is missing. It's not coming. No, that's a blocking. It's not coming. That's what you have to look. Jitter, which the machine is calculating for you, and there are norms, and blocking when the fiber doesn't come. And then it's the most sensitive test, as we said, could be up to 95, 99% positive. It's very sensitive, but not specific. It can be abnormal in neuropathic patients and myopathic disease. No, an ALS case can have an abnormality. I have a case which we try to publish right now that has a single fiber, which is abnormal, has a congenital myopathy in a mitochondrial disorder, and he had droopy eyes. One of our colleagues from movement disorder from Maimonides sent that patient to me, and his single fiber was positive. Then be very careful. It is recommended to be performed in patients in whom the diagnosis of myasthenia or neuromuscular is strongly suspected, no, like that case that we have with droopy eyes and the surgery didn't help. And in some patients with restricted ocular myasthenia, all studies, including single fiber, may be normal sometimes. Then don't blame the technician, but sometimes the single fiber can be normal in their situation too. And this is what I had. And now if you have any questions, I'm here to answer.
Thank you so much, Dr. Treidle. This was very helpful. I do have a question. You mentioned that, but I did not get it. I did not process it. So how long before EMG nerve conduction study should we stop acetylcholinesterase inhibitor before the EMG nerve conduction study?
The periodic mean?
Yes,
Yeah, 12 hours. Yeah, at least 12 hours. It's good to say 24 hours if you want, but 12 hours should be enough.
Thank you so much. And the other question is for single fiber EMG. So now we know that patient with ocular negative with high suspicion for myasthenia gravis, we refer them for single fiber EMG. But what are other scenarios? Like, for example, can we use it to diagnose suspected botulism, for example, or maybe other myasthenia gravis other than ocular findings? What's the utility of it?
Yeah, then you can always ask for a single fiber EMG when you have a case that's bothering you. It really looks that has fatigability that fluctuates. No, it's a neuromuscular, or you have a suspicion of a botulism, which is very rarely to come on their feet. But if they can come, you know, on a consultation, no, you have always to look for the autonomic dysfunction. Yes, it's not only used for single fiber. No, then if I mentioned to you about that case that I had with one of my colleagues from Maimonides, a movement disorder specialist, she sent that patient to me for droopy eyes, and they were very nice droopy eyes, which didn't have fatigability. And another thing that they didn't have, he was not complaining of diplopia. He was a technician that was looking at the cardiac monitors, but his eyes were very droopy, no? Then I did a single fiber EMG, and that single fiber EMG was positive. And why was that? Because those frontalis muscles were weak, no? Then you see, you can use a single fiber to help you diagnose something else. And then I sent back a message to her. That patient has a little bit of spasticity. You notice some dystonic posture of the foot, no? And the eyes are droopy. You're correct, should be a more systemic disease. That's how we diagnose that patient with a type of hereditary spastic paraplegia, which is a mitochondrial abnormality. Then you can use single fiber to help yourself, especially it's an academic place, and you have a case like that now with ptosis.
Very helpful. Thank you, Dr. Treidle.
Any other questions you have?
Dr. Treidle, thank you. So I have a question regarding the, I think the graph you showed that when the EPP is lower than the threshold, that like the difference between the MG EMS. So I'm wondering if the EPP is lower than the threshold, why would you at all be able to record a muscle action potential?
Yeah, that's a very good question. And in general, you record a very minimal muscle potential or nothing, but you know that the patient can move. That's your exercise that you do on LEMS patients. You remember, you don't get your deep tendon reflexes, and then the attending comes and the patient moved already and the deep tendon reflexes are coming up. That's a very interesting particularity. Then when you see a case like that, you stimulate and you get no response, but clinically that patient was moving the thumb or the pinky, you should ask them to exercise. Bring them up a little bit, 10 seconds, push as strong as you get, and you're gonna get this incremental response. I think your question is very good. Electrophysiologically, you see that the end plate doesn't, but because of the safety factor, you're gonna see a little bit of one compound or absolutely nothing, activate, and you see an incremental response.
Okay, thanks.
Am I clear? Yeah. Okay, any other questions? Okay, good. Then if you have any other questions, you don't hesitate to send me a message, Johannes, and many of you at my email. And then if you have a case that you want to diagnose, I'm really happy to help with the single fiber.
Thank you so much, Dr. Treidle. Excellent talk as always. Thank you for taking the time.
You're very welcome. Take care. Take care. Bye-bye.